Now, the anatomy of the large intestine. When the large intestine, as we mentioned, the major role, okay, is absorption of water and salt. Most of the nutrients have been absorbed in the small intestine. They've been digested and absorbed in the small intestine. The large intestine absorbs most of the water, 90% of the water from the content entry and the salt, and it solidifies the contents to form stool. And the distal parts, which is the rectum, serve as a reservoir for this stool, because when the content just go down, it doesn't just go out. It has to be stored in the rectum, okay, before it's completely evacuated. Now, this large intestine is about 150 centimeters long, even though the length varies from individual to individual. But the average length of the large intestine is about 150 centimeters long. That's why the average and the standard length of the scope for colonoscopy is about 160 centimeters. Okay, it's about 10 centimeters longer than the entire length of the large intestine. And you should know the classical features of the large intestine that differentiate it from the small intestine is one, the volvulae conventis, which we shall, the appendices epiploicae, which we shall see, the tinea coli, and as well as the haustral markings. These are the three features that give the large intestine its characteristic feature. The appendices epiploicae, which are pockets of fats you can see and are more concentrated in the sigmoid. The tinea coli, which you see here, as well as the haustrations. And of these three features, it is only the haustral markings that you can see radiologically. Now, what are the various parts of the large intestine? Now, the cecum and appendix are part of the large intestine. You have the ascending colon, the hepatic flexure here, then the transverse colon, then you have the splenic flexure here, the descending colon, then the sigmoid colon, then the rectum. It ends as the rectum. The anal canal is a separate entity. So we'll discuss the anatomy of the rectum and anal canal as a separate entity. Now you should know that this structure of the large intestine, it progressively reduces in caliber from the right side to the left side. So the most dilated portion of the large intestine is the cecum. The most dilated portion of the large intestine is the cecum, and it progressively decreases in caliber from the right side to the left side. And this is very significant surgically for you to know that that's why tumors in the right side hardly cause intestinal obstruction, because the caliber is larger. That this is one of the reasons. The other two reasons are the constituent here is liquid on the right side, while on the left side, as it goes down, most of the water has been absorbed is solid. The third reason has to do with the pathology of the tumors. Most of these ones here are ulcerative and cauliflower type, while on the right side, they are annular, like ring form or tubular. So you should know on the right side, the colon has a wider caliber. 2, it has more, the content is liquid. And 3, most of the pathology have flat nature. So obstruction is unlikely to occur on the right side. And you should also know that most of the bleeding occurring from pathology, okay, tumors in the right side commonly bleeds as compared to the left side. So the cecum, as we mentioned, is the most dilated portion of the large intestine. The ascending colon is about 5 to 8 inches. The hepatic flexure, okay, because the liver is here, so it's related to the liver, is called the hepatic flexure. And you will see the significance of this shortly. Then the transverse colon is about 18 inches. Splenic flexure, descending colon, about 9 to 12 inches. Then the sigmoid colon is 15 inches. So you can see, don't forget, the transverse colon is the longest portion of the large intestine, followed by the sigmoid colon. The rectum is 5 inches, and the anal canal, which is a separate entity, is 4 centimeters, about 1.5 inches. Now, this transverse colon and the sigmoid colon, they have mesentery, okay? So they are fully intraperitoneal. They are fully intraperitoneal. And before I forget, it is because of this anatomy, the transverse colon and the sigmoid colon are used for siting colostomy. These other portions are plastered to the posterior abdominal wall, where only their anterior and lateral surfaces have peritoneum. Their posterior surface is retroperitoneal. Now, we've mentioned this, that the characteristics of the large colon are the appendices pleurae, which are pockets of fats, okay, that are more numerous in the sigmoid colon. The tinea coli in the cecum and colon. These tinea coli are 3 in numbers, and they are what? They are condensation of the longitudinal muscle of the large intestine. They are nothing but condensation of the longitudinal muscles of the large intestine that all unite at the base of the appendix. So if you are doing an appendectomy and you have difficulty in locating the appendix, what you just do, you trace the tinea coli. It will guide you and lead you to the base of the appendix. And if you cannot get the tip because of difficulty where it is hiding, you now do what is called retrograde appendicectomy or retrograde appendectomy. So that is the tinea coli. What do they arise from? The longitudinal muscle of the large intestine. The transverse and the sigmoid colon are peritonized, thus have mesentery, but the ascending and descending colon adhere directly to the posterior abdominal wall. Now, there's one important feature of this rectum, okay, where it is only the anterior portion, okay, of the upper part, middle part, that has peritoneum. And the sides, anterior and sides of the upper and the middle portion. But the posterior portion of the upper and the middle parts and the entire portion of the distal 1/3 are retroperitoneal. The rectum is extraperitoneal on its posterior aspect of the upper 1/3, posterior and lateral in the middle 1/3, posterior and lateral, okay? They are extraperitoneal, and completely extraperitoneal in the distal 1/3, below the pelvic peritoneum, because the peritoneum reflects at that portion in females to form the pouch of Douglas, okay? While in males, it will form the rectovesical pouch. So the distal 1/3 is completely extraperitoneal. Now, one of the important anatomies that have significant surgical relevance in the large intestine, it's the relation. Now, before we discuss the relation, just note that one surgery we do is called, one surgery that is commonly done is the right hemicolectomy. Now, when you become a senior registrar in general surgery, one of the important surgeries that you should learn early is right hemicolectomies. The reason, sometimes you might have some difficulties even operating the appendix, in which the treatment you will do might be right hemicolectomy. Sometimes you might find injury. Sometimes it is a typhoid perforation that you cannot close primarily. You have to resect. It's just at the terminal ileum. So you will always be on call, and you will be one taking those emergencies. So right hemicolectomy is something you should be able to do. And remember, there are 3 important structures that are injured during this procedure. 1, the ureter, the right ureter, okay? 2, the gonadal vessels, and 3, the second part of the duodenum. Because when you reflect this right colon up to the hepatic flexure and mobilize it forward, you will see the second part of the duodenum, and if you are not careful, you enjoy it. The gonadal vessels, as well as the right ureters, because you will see how these structures are lying posterior to this colon. The ascending colon, posteriorly, it crosses the right iliac crest, ascends in front of the quadratus lumborum and the psoas muscle. This one is not too, they are just muscles, you can see. Okay, you see how it ascends. Now, what I want to draw your attention here, why I gave you example of this right hemicolectomy, is this. Right ureters, right gonadal vessels, okay? There was several, even when I was a registrar, when I was operating with one of my senior registrar, he just transected the ureter. We were just going, before you know it, we start seeing urine filling the peritoneal cavity. So we now have to repair that. We called urology, we repaired it over a stent. Recently, not long ago, I think 2 months ago, the gynecologist called me. They were in for a huge ovarian tumor, And when they got in, they found out that it is actually a cecal pole tumor. And that cecal pole tumor has obstructed the distal ureter as it crosses it. So there is no way we have to, because it has infiltrated. In fact, the patient had hydroureters, hydronephrosis. We have to divide that ureter at that point where it entered the tumor and reimplant it into the bladder. So you must know that this ureter is posteriorly related to this ascending colon as well as the descending colon. Okay, it makes a right angle bend in front of the lower pole of the right kidneys. Okay, at the hepatic flexure to become a transverse colon. And at that hepatic flexure, medially, don't forget, it is related, that is posterior medially, the second part of the duodenum is there. So don't forget this tree structure. If they are to ask you any question regarding the posterior relation of this colon, these are the three structures that you will be asked. The ureter, the gonadal vessels, as well as the duodenum. So I told you all these stories so that you don't forget. Transverse colon. Now, superiorly, okay, the liver, the gallbladder, and the stomach. If you remember when we did the anatomy of the stomach, we said among structures that form the stomach bed is the what? Transverse colon, okay? It is attached to the greater curvature of the stomach by gastrocolic ligaments, part of the greater omentum. And of course, this relation is very important in cases of transverse colon tumor, okay, or some gastric tumor. Sometimes in advanced cases, they attach to the stomach, or if it is gastric tumor, it's attached to the transverse colon, and it becomes unresectable. Or sometimes they may even form a gastrocolic fistula, where the contents of the transverse colon enters the stomach. And don't forget, anytime you have abnormal contents in the stomach, it tends to irritate the mucosa. For example, when you have reflux of duodenal content into the stomach, it irritates the stomach mucosa, okay, causing gastritis, and patient vomits. Now, if you have feces entering, patient vomits, and patient will be having feculent vomiting. Now, superiorly, then posteriorly in front of the right kidney, second part of the duodenum, and head of the pancreas. That is a posterior relation of the transverse colon. It makes acute angle at splenic flexure to become descending colon. Descending colon descends in front of the left kidney, the left ureters. You can see these two structures are featured here, the left ureter and the left gonadal vessels, and the left iliac crest where it becomes sigmoid colon at the pelvic brim. So the sigmoid colon commences at the pelvic brim. And don't forget, this sigmoid colon has a mesentery. Now, the sigmoid colon is related to the bladder anteriorly and the coils of the ileum. Now, sometimes this sigmoid colon will have a very long mesentery. I'll When they have long mesentery, they are prone to sigmoid volvulus. Okay, that's it. It just twists along about its mesentery. And when there's volvulus, they'll form that closed loop we are talking about. Now, what is the blood supply to the colon? Now, the blood supply of the colon is from branches of the superior and inferior mesenteric vessels. The blood supply to the colon are from branches of the superior and inferior mesenteric vessels. Okay, let us see. This is the transverse colon, this is the ascending, descending, sigmoid, and rectum. Okay. You have superior mesenteric artery from abdominal aorta, the inferior mesenteric artery. Now, branches of the superior mesenteric artery supplies the ascending, cecum ascending colon and the transverse colon. Branches from the inferior mesenteric artery supply parts of the transverse colon, descending colon, and sigmoid and rectum. What are these branches? You have ileocecal branch supplying the terminal ileum as well as the cecum and appendix. One, you have ileocecal artery. Okay. There is the right colic artery. Now, this arterial supply is very important because it forms the basis for our surgical resection. Not the arterial supply per se, but the lymphatic drainage. But because the lymphatic drainage runs along the arterial supply, and that is why you have to consider the arterial distribution. So you call it the lymphovascular distribution. So these are branch that supplies up to the proximal 1/3 of the transverse colon. The ileocecal artery also have branch that is ascending and anastomosing from branch coming from the what? Right colic artery. Then you have the middle colic artery. The middle colic artery divides into two branches, the right, okay, and the left branch. You can see it is supplying the transverse colon from the proximal 1/3, okay, and you can see it is coming up to the proximal 2/3. How many branches have we mentioned? We've mentioned the ileocolic. We've mentioned the right colic. And we mentioned the middle colic. So these are three branches from the superior mesenteric artery that is supplying the right side of the colon. Even though there's another branch of the superior mesenteric artery we discussed while we are talking about duodenum, the superior pancreaticoduodenal artery, it has no business here from the name, pancreaticoduodenal. But the branches that are concerned with the colon are ileocolic branch, the right colic branch, and the middle colic branch. Okay? And you can see how they supply the colon. Now, the inferior mesenteric artery, it has the left colic branch. Okay? It has sigmoidal branches supplying the sigmoid, and it ends as the superior rectal artery. Okay? The left colic branch has ascending branch and a descending branch. You can see the ascending branch is anastomosing with the left branch of the middle colic artery. So what are these branches? We said the inferior mesenteric artery has the left colic artery, okay, the sigmoidal arteries, and it ends as the superior when we discuss the rectum, we'll talk more on these superior rectal arteries. And you can see how all these vessels now form an arterial anastomosis of arcades. Now, at this point where you have anastomosis of the superior branches of the mesenteric arteries, they are called watershed areas. So let me give you an assignment. Let me give you 3 assignments. I'll ask you tomorrow. The first assignment is what are watershed areas? Two, SUDEC critical point. SUDEC critical point. 3, arc of Roland. So I'll ask you tomorrow in our lecture for tomorrow, before we take the rectum and the anal canal, if you don't tell me this assignment, we won't proceed. The arc of Roland and their clinical significance, critical point, SUDEC critical point or critical point of SUDEC, and what are the watershed areas. Okay, let's go back. Now, you can see all these vessels form anastomosis. If you notice, they now form an arc. Okay, they now form like an arterial arcade at the margin, at the inner margin of the colon. It just as if it's a single vessel now because they all anastomose. So this is called the marginal artery of Drummond. The marginal artery of Drummond, they all anastomose. Okay, so let's go back to our slide. I believe you understand how the distribution of the arterial supply of the colon is. Now, what you should know about this distribution, the lymphatic drainage of the colon runs along these vessels. Okay, I actually wanted this to be a separate lecture so that we are going to discuss in detail, but okay. So the large bowel receive blood from the superior and inferior mesenteric arteries. We mentioned that from the superior mesenteric artery. So you should have a mental picture of what I'm reading now. The ileocholic artery or ileocecal artery supplies the terminal ileum, cecum, and commencement of the ascending colon. It gives off an appendicular branch to the appendix. The right colic artery supplies the ascending colon. The middle colic artery supplies the transverse colon. I remember how and the branches. The inferior mesenteric artery, okay, is what the left colic supplying this descending colon, sigmoid branches to the sigmoid colon, the superior rectal or hemorrhoidal to the rectum, which is the terminal branch of the inferior mesenteric artery. The veins, okay? The veins follow the artery. Superior mesenteric artery arises from the abdominal aorta at L1, okay? While the inferior mesenteric artery gives off at the level of L3. Okay, this is all what we just described. Now, you should also note that the lymphatics of the colon are distributed in 3 tiers. Okay. There are lymphatics that are epicolic. You can call it epicolic, you can call it paracolic, just at the epicolic group of lymph nodes. And there are those that run along the blood vessels, okay? There are those that run along blood vessels, along the branches, okay, of these blood vessels. Because the lymphatic go along the blood vessels. And there are those that are around the para-aortic. If this is the aorta, there are those that are para-aortic. So you can see from those that are just adjacent to the colon, they drain into the intermediate node, and they finally drain into the para-aortic group of lymph nodes. So that is how the drainage is distributed, okay? Lymphatic drainage from para-aortic paraenteric, paracolic nodes, okay, to nodes in the mesentery, then to the para-aortic group of lymph nodes. So you can see there are three tiers of lymph nodes. From there to efferent vessels that link up to drain into the cysternal chyli and ultimately into the thoracic ducts. So you can see why tumors, even in the abdomen, even from the colon, can even present with what? Trosia sign, vitreous node, because that thoracic duct will drain into the junction between the left subclavian vein and the internal jugular vein. So tumor can also deposit at that junction in the left you now palpate a node in the left supraclavicular region. The lymphatic field of each segment of bowel corresponds fairly accurately to the blood supply. We are going to talk about this shortly. So we will not go into rectum and anal canal. Let me talk about this, then we'll stop here. Okay? It's very important you understand this. Now, the lymphatic distribution of the colon goes along with the blood vessels, the blood supply. Now, this determines the type of surgery that is done for the colon. Let us see the various types and why. Okay, this is the appendix, cecum, ascending colon, transverse colon, descending colon, sigmoid, and rectum. You have the superior mesenteric vessel as well as the what? Inferior mesenteric vessel. This is the ileocolic branch. This is the right colic branch. This is the middle colic branch. Okay, don't forget your marginal artery of Drummond. Okay. This is the left colic that has ascending branch. You have sigmoidal branches. Okay. Tumors are drained following lymphatic channels that are along these blood vessels. So if you have a tumor in the cecum, tumor in the ascending colon, what will happen? Because they will drain following these lymphatics are around these branches. So because the epicolic node will be here, it will drain to this side, but it will not affect this one going to this because your anastomosis stops here. So when you have tumor, even if it's in the cecum or appendix, as long as it is malignant, you don't just go and take off this, because why? You can see lymphatics here. It will still spread. So what you will do, tumor in the cecum, ascending colon, you will do what is called right hemicolectomy. And all these vessels are removed along. Okay? All the branches, not the superior mesenteric vessel. It's the branches. you ligate at the point where the branches come out. So this is called right hemicolectomy. If you see a malignant tumor here, even if it's in the cecum, don't just do limited resection. You have to take it up to the proximal 1/3 of the transverse colon. And this is the base on which vessel now? It is based on right colic vessel. Right colic vessel. Because why is it based on right colic vessel? Because the right colic vessel branches to anastomose with a branch of the middle colic artery at the proximal 1/3 of the transverse colon. If you have a tumor in the hepatic flexure, you have to extend your resection now, okay? If the tumor is in the hepatic flexure, you do what is called extended right hemicolectomy. You extend your resection to the proximal 2/3 of the transverse colon. That is called extended right hemicolectomy. If the tumor is in the transverse colon, you do what is called transverse colectomy. You just resect the transverse colon, including both flexures, both the hepatic and splenic flexure. If the tumor is in the descending colon, you do what is called left hemicolectomy, okay, up to the proximal 1/3 of the sigmoid. If it's on the sigmoid colon, you do sigmoid colectomy because its branches are separate. So you have to take only the sigmoid along with its branches at the point of ligation. Why the surgery for rectum is completely different. We'll talk about that. So the various surgeries you do include right hemicolectomy, extended right hemicolectomy, transverse colectomy, left hemicolectomy, left hemicolectomy, sigmoid colectomy. Okay. So, any question? If you have any question, you ask. Any question? Okay, you don't have any questions.
Thank you, sir.
Okay, no.
Thank you for the lecture, sir.
Okay.
I had a question from the previous topic, but
And
I was talking. Maybe I think my network was poor.
You are the one that was hacking Dr. Halima's device.
I wish I could, sir.
Because we noticed there is a hacker. There is a hacker. Hope you did not pick our account.
Hacking for top computer gurus, sir.
We don't know who you are now, especially in this period where subsidy has been removed. Yes, what is the question?
I've heard of a blind loop syndrome. So I don't know. Maybe if you can shed light on this.
Blind loop syndrome, that is related to duodenum. Okay.
Okay.
Blind loop syndrome is related to duodenum. And I will not tell you here because it's not related to this lecture we did. If it was
Okay.
who and why, if it was who and why you asked, I would have told you. Okay, but go and read it. Blind loop
Okay, sir.
syndrome related because the blind
Okay,
loop
sir.
is actually a duodenal loop. Okay, so go and read about it. Any other question? Okay, somebody posted that no question. So we are going to stop here and continue tomorrow. And you should all check on my assignments. So thank you very much, everyone.
Thank you, sir.
Thank you, sir.